Good morning. Today we have a great lecture by Dr. Metz. Dr. Metz, for those of you who do not know him, is a tenured professor and chair of Department of Anesthesiology at Penn State University. I know we have several people from Penn State. We have a new resident, but I don't see him yet. Anyways, he's formerly in, where is he? Formerly, Dr. Metz was in New York City at Columbia, and he was the program director and associate professor of anesthesiology there. He also was formerly the president of the Society of Academic Anesthesia Associations and Association of Academic Anesthesia Chairs, as well as the president of Society for Education in Anesthesia. So those two organizations, for those who don't know, are devoted to our field, the education in our field, and the future of our field. He currently is the Director of Partnerships on the board of the World Federations of Societies of Anesthesiology and the Chair of Global Humanitarian Outreach Committee of the American Society of Anesthesiologists. So very interested in global outreach for anesthesia. He's well published. He got his degree in the Republic of South Africa, his PhD in pharmacology at the University of Cape Town. He's a fellow of the Royal College of Anesthetists of the United Kingdom, as well as a fellow of the College of Medicine of South Africa. And so we're very grateful to have Dr. Metz today. Please welcome.
Thanks, Julie. Good morning, and thank you for the invitation to come here. Unfortunately, I have no disclosures, except that I'm very well and concerned about not contriving to bring coals to Newcastle in this presentation, which I've entitled A Brief History of Anesthesia, a Balance Between Safety and Death. And here's why. In what some considered the first general anesthetic, Horace Wells self-administered nitrous oxide to unconsciousness for a tooth extraction. The dentist, Dr. John Riggs, remarked, "We knew not whether death or success confronted us." The happy outcome of this I will relate for you later. Before general anesthesia, this is what an amputation looked like in a London hospital. The only operating room was seated at the top of the hospital for two reasons. The first, so that ambient light could come through the skylight to light up the proceedings, and the second, so that when surgery was about to commence, a bell would be rung, the door would be closed, so when the screaming started, it wouldn't emanate and penetrate to the rest of the hospital. Now, for a general surgery before general anesthetic, the patient would usually be supported in, would be a little bit inebriated and pinned down by 5 stout men, as you see here. A 6th would steady the leg. The surgeon would get his tools ready, apply a tourniquet, and put a surgeon's stick in the patient's mouth. Then the audience would rise, and at a time where they prized speed in surgery, they would whip out their stop clocks and time the surgeon. Dr. John Liston, the preeminent surgeon in this hospital, was so fast he could do it in 25 seconds. On one occasion, before general anesthesia was started, he was so fast that he cut through both the patient's leg, the assistant's hand, both dying of sepsis, and one of the people in the audience took fright, keeled over, and died. The only surgery with 300% mortality. Mortality was a problem. 1 in 2 patients dying after surgery of either sepsis or pain. And the pain was so excruciating that many surgeons that had to apply their craft would either vomit before or after the procedures from this excruciating event. It was thus not surprising that in 1846, with the announcement of the first general anesthetic, that this was met with loud applause. I've separated the talk to start off by talking about anesthesia by alternative methods before this event in 1846. Then the story of general anesthesia, gases and vapors. And then an aside including intravenous anesthesia and muscle relaxing, building the concept of balanced anesthesia. Then I will cover some of the aspects that enhance safety in anesthesia and discuss improving outcomes, a 90-fold improvement in the last 60 years. And then I will muse on a balance between anesthesia, safety versus toxicity. Here's the definition. Anesthesia is equivalent to insensibility, defined by many people that you see here, and it's a well-known triad of anesthesia: narcosis, analgesia, and muscle relaxation. Before 1846, there were numerous alternative methods of providing anesthesia, most unreliable. With respect to physical means, the Napoleonic surgeon Dominique Loret applied a blow to the patient's head to extricate the bullet from his foot. A blow to the side of the head was a well-recognized surgical strategy to do an operation. Carotid neck obstruction was another approach. Either through finger pressure or a noose around the neck, the patient would be throttled till blue, collapse, and the circumcision could be rapidly performed. Physical pressure was also used, especially with a tourniquet, to deaden the pain from nerves during amputation. Now, there were acolytes for mesmerism or hypnotism, but most surgeons didn't think this was very effective. Upon performing an amputation under the first ether anesthetic in London, Dr. John Liston remarked, "This Yankee dodge beats mesmerism hollow," verifying the fact that they really didn't believe much in mesmerism. Of the known drugs, alcohol would seem to be an agent that could be used with great utility for general anesthesia. Unfortunately, it is unreliable. If you give too much, the patient starts vomiting, and so you can't give any more, unless you give by rectum, which is also unreliable. Patients would become obstreperous, needed to be tied down, or they would vomit and aspirate and die. Extracts from the poppy seed had been used extensively, but again, overdose would cause respiratory death. And mandragora and belladonna both caused overheating. The problem with all of these agents before 1846 was that they were non-standardized lethal concoctions. To tell the story of gases and vapors, we need to crisscross from the New World to the Old World, starting in Leeds, England. Here we meet Joseph Priestley, the son of a hand-loom weaver. He was educated and scholarly and became a preacher, teacher, and scientist. In 1792, he synthesized nitrous oxide by focusing sunlight on iron filings in the presence of water and nitric acid. He was a prolific writer, writing 3 books on air and the air creations that he created. But he found that nitrous oxide was poisonous. It killed his mice, and so he had no further use for it. Henry Hill Hickman made a singular contribution to the anesthetic story. He contributed that anesthesia might be delivered as a gas. He studied suspended animation. Knowing full well in 1825 Priestley's writings, he realized that a mice needed oxygen to survive. So what he did is he took his dog and put it under the dog. He put his dog underneath the glass canister that you see here. The dog would pant away, carbon dioxide would be built up, the dog would become narcotized. He'd extricate the dog, chop off its ear, and demonstrate painless surgery. He presented his findings at the Royal Society of Medicine in London, but there was no interest demonstrated in this approach. And defeated, he committed suicide as a result. We now move to Bristol, where we find Dr. Beddoes, who wanted to use medical therapy, gaseous therapy, to provide medical care. He developed a novel laboratory clinic to do this process, and what he wanted to do is apply much of Priestley's writings and findings of different gases to treat common respiratory ailments like tuberculosis and bronchiectasis that were renowned in the polluted England of the time. Now, he was a very busy man, so he needed a superintendent for the laboratory. Unfortunately, he heard of a rakish young chemist by the name of Humphrey Davy. Humphrey was 21 and fearless, and was put to the task to figure out what to do with nitrous oxide. Now, Humphrey had read Priestley's writings too, and knew that this was poisonous. So he didn't want to experiment with the laboratory's chickens, and instead he experimented on himself. Tasked with doing a presentation to a gathered audience on the 11th January of 1799, he prepared some nitrous oxide in a silk bag, sat back in a chair, inhaled 4 times deeply, and lay back stuporous and blue, much to the alarm of the surrounding people in the audience. Then he coughed, and he coughed, and he started giggling, and then he laughed. And so nitrous oxide became the medical therapy that it was used for in the future, and laughing gas parties became de jour, both in the old as well as in the new world. Where we turn now to Gardner Colton, an impecunious medical student at Columbia Presbyterian. To supplement his meager income, Gardner would give talks to a ladies' club in New York City, demonstrating nitrous oxide. Of hearing of the frivolity that ensued, his fellow medical students said, "Gardner, you need to go commercial. Why don't you hire the Broadway Tabernacle and do a public demonstration and make some money out of it?" So he hired the Broadway Tabernacle, advertised widely for a date of March 19th, 1844, and pointed out that there would be 34 young men volunteering to take the gas and 12 stout men to stop volunteers from injury because they would cohort around. The day arrived. He had a steep price at the door, 25 cents, but there was a large crowd, place filled up completely. When the whole place was full, Gardner leaped onto the stage to give his lecture and demonstration, recounting some of Priestley's findings 70 years before. The whole affair was a laughing success. He earned $535 and went back to medical school, and also decided to go and do presentations around the country, including a grand exhibition in Hartford, Connecticut. Now here he met Horace Wells. Horace Wells was a disturbed man, not at first, but later in life. He came from a very good family, went to dental school, and thus was always concerned about the pain he caused from tooth extraction. He was scientifically minded, and on reading about the grand exhibition in the Hartford Courant, he decided to go. Next day, he paid his 25 cents, sat down at the bottom of the stage, and watched the proceedings. Gardner reprised his nitrous oxide presentation and then handed out nitrous oxide to anybody who would take it. Horace was first up onto the stage, cavorted around, making a royal fool of himself, and sat down again, just like you guys are sitting here, and watched the proceedings. As his dental assistant, Sam Cooley, stepped up onto the stage, took some nitrous oxide, and careened into a stool. On coming down and sitting next to him again in the audience, Horace turned to Sam Cooley and said, "Did you feel any pain?" And Sam said, "No, I didn't." So he waited to the end of the proceedings, and he went over to Gardner and said, "Gardner, have you ever used nitrous oxide for teeth pulling?" And Gardner said, "No, but I'll make you some. Why don't we try it out?" And so, in what some consider the first general anesthetic, Horace Wells imbibes the nitrous oxide deeply until he is completely blue and stuporous and unconscious. And John Riggs remarks, "We knew not whether death or success confronted us." And then they waited, and they waited. And then suddenly Horace coughed, and feeling the gap in his teeth, he got up excitedly and remarked, "It is the greatest discovery ever made. I didn't feel as much as a pinprick," and proceeded over the next days to advertise this new era in tooth pulling throughout Hartford, Connecticut. It was thus not surprising that soon he received an invitation from William Morton, a dental associate from Boston, to give a presentation here at the Massachusetts General Hospital, where the preeminent surgeon was Dr. John C. Warren. As the preeminent surgeon, he was very concerned about the pain caused by surgery and would love to have heard of a solution, so he was very interested in this demonstration. January 1845 dawned, and Horace Wells prepared to do his demonstration here at the Massachusetts General Hospital. He first gave a lecture on laughing gas for teeth pulling, and then applied the nitrous oxide nervously. He was nervous because he didn't have the same Sam Cooley produced strain of nitrous oxide that he had back at home. And he said later that he pulled out the bladder bag too quickly. The result, as he starts pulling, the patient cries out and groans, and the whole audience starts yelling, "Humbug, humbug, humbug." And he ignominiously exits from the theater, goes home, closes his dental practice, moves to New York City, where he commits suicide from a femoral laceration and an overdose of chloroform. Watching carefully in the audience that day was a man by the name of William Morton. Strikingly attractive, he was always in a hurry. Usually a hurry to make money. That's what the textbooks say. It's not my own opinion. He was always in a hurry, usually a hurry to make money. He was a trickster and a swindler, wanted in 3 states for embezzlement before any of what you're about to hear happened. Now, it's not quite clear how he thought about using ether for surgery. Some say that he heard it from Charles Jackson. Others say that he says that he heard about it from ether frolics. Whatever the truth of the matter, what is known is that he publicly advertised offering $5 to anybody who would sit for a public demonstration. That night, Eben Frost appeared at his door and putting some ether onto a towel, as you see there, he placed it over Eben Frost's face, who succumbed, and they pulled out the teeth. He needed to be roused with a whole lot of water thrown over his face, and so was the first anesthetic with ether demonstrated. Reported the very next day in the Boston Journal, because Morton had invited the journalist Albertini to be present at this event. Morton lost no time in practicing on 37 patients and hires an agent to submit a patent application for lithium. Now, everybody knew he was using sulfuric acid, but to try and disguise that fact, he mixed it with oil of orange essence to try and disguise the signature smell that the sulfuric ether had. He then too was invited by John C. Warren on October the 15th to demonstrate his painless surgery the next day. But Morton was completely unprepared for this. He panicked. The problem for him was that he wanted to show an invention and not just ether on a handkerchief to a patient. So he consulted with Dr. Gold, who created for him overnight this device that you see in front of you, a retort glass with a beer barrel spigot stuck in the one side, and then with a sponge in the inside that would increase the vaporizing surface for ether. October 16, 1846 dawns, and the operating room is prepared. The who's who of medicine has arrived, including Eben Frost, as well as a photographer. The patient is Gilbert Abbott. He'd had a jaw tumor from birth. He was slovenly dressed, so they described miserable, thin, and weak. Start time was 10 o'clock, and he was shackled to the bed just in case. No Morton. Dr. John Warren paces around. Dr. Haywood, his assistant, said, "Should we start?" Warren says, "No." Turns to the audience and says, "I've heard there is a man who will give a certain agent and allow us to do painless surgery. We must wait and give him the opportunity to demonstrate." Morton hurtles in. He knows he's late, but he's had to finish preparing the contraption, his apparatus, so he can use it on this demonstration. He's never tested this apparatus, and he walks in, and the surgeon, Warren, says, "Your patient's ready." He says, "I know." And he walks over to the patient, Gilbert Abbott, and he said, "Are you worried?" And Gilbert says, "No, I trust you completely." He then takes the inhaler and sponge filled with ether, puts some ether in, and puts the spigot in Abbott's mouth and says, inhale deeply. Now, as he's doing this, he's thinking what his wife told him back at home. You will fail, or you will kill the patient and be tried for manslaughter, is what she said. But he doesn't look nervous at all. He doesn't look nervous. 5 minutes later, he turns to Warren and says, your patient is ready, sir. And Warren cuts. There is a stunned silence. The patient lies completely still. The blood oozes out of the wound. 10 minutes later, the surgery is over. Warren turns around to the whole audience and says, gentlemen, this is no humbug. There's a gasp and there's loud clapping for this seminal event. Within 2 months, there's a public paper in the Boston Medical and Surgical Journal entitled Insensibility During Surgical Operations Produced by Inhalation. This fact takes the world by storm. Now, Morton starts off quite a rich man, but when the ether question, the question for primacy around ether, reared its ugly head, he petitioned Congress 4 times for 100,000 for this invention. Unfortunately, he was denied, and so he died a broken man. In 1868, there was a fearsome heat wave in New York City. He had pinned 3 medallions that he'd received from foreign governments for his invention, and was seeking to leave New York City, and died in an apoplectic fit on the way to St. Luke's Hospital in a carriage. Nevertheless, this is what's on his tombstone here in the Auburn Cemetery. Inventor and revealer of inhalational anesthesia, and both of these were written by Henry Bigelow, who was one of his chief champions here at the Massachusetts General Hospital. He was a dentist. The problem for the primacy of ether for Morton was that he wasn't first. The person who was first was, of course, Crawford Long, a man of modest pretensions. Crawford was an excellent doctor. In fact, he was late to his own wedding. And after going to his wedding, he was concerned about a patient, so he left, went and took care of the patient, and only returned to the marriage bed 24 hours later. Soon after the wedding, his friends asked him to make some nitrous oxide, but he didn't know how to do it. So he said, I'll make some ether instead. And so they developed the approach of having ether jollification parties. At one of these jollification parties, he noticed that when he bruised himself and thrashed around, he didn't have any pain. Now, one of the partygoers was a man by the name of James Venables, who had, again, 2 cysts on the neck, who was incredibly fearful of having them excised. So, making James Venables accustomed to ether through the parties, on March the 30th, note the date, 1842, he threw ether on a towel, rendered Venables unconscious, and removed the cyst. 3 months later, he did an amputation under anesthesia and 9 documented anesthetics before the October 1846 date. So when he heard about the claims of primacy from Morton, he decided to publish, and publish he did, in the Southern Medical and Surgical Journal. It's fantastic to examine this. It's got affidavits on everybody that these were the real anesthetics given by the people and they were the patients. So this solidified the claim that Crawford Long was the first anesthetist, and he is, of course, and we are credited with the first general anesthetic, and Doctors' Day in the USA is held on March the 30th. Now we must go back to the old world. 2 months later, through a letter from Henry Bigelow to Dr. Booth, the first ether anesthetic is given in London. The major protagonist in London is Dr. John Snow. He's a vegan and a teetotaler. Nevertheless, this pub is named after him. By the way, I took this photo from this pub of him. It's a very nice pub. Please go. John was both an epidemiologist as well as a doctor. And he is also probably the author of the first anesthetic textbooks in 1847. He was so concerned with the method of ether handkerchief administration, crediting it with the fact that it killed one of his horses, that he developed his own anesthetic device in 1847, notice, a coil for better vaporation, but importantly, a mask which would minimize the obstruction from a cloth full of ether. He also wrote out the 5 stages of anesthesia. We now go to Edinburgh, where Dr. James Young Simpson started his professorship under a cloud. He'd pay £500 to get the position, but he was a great lecturer and also a great user of ether. He, however, was concerned about ether, stating that it smelled, made people sick, it was flammable, and it was made in America. That was the worst of all. A robust man, he favored dinner parties, which would conclude with on the menu various chemicals that they would imbibe, particularly for their volatility, because of course alcohol, they'd like to have a party after. And one day chloroform was on the menu, and he recounts that he woke up under the table, and so chloroform was the next serendipitously found anesthetic. Popularized in the United Kingdom by Simpson, Snow, and Clover, there was one big problem. The church had resistance in minimizing pain from obstetric delivery. So he engaged the Queen Victoria, who was administered that blessed chloroform for her 8th delivery, and after that chloroform was popularized. The problem with chloroform was that it killed, unpredictably. Hannah Greener had had a previous toe operation under ether anesthesia, but now she was coming back for a second operation, and she was exceptionally nervous. They had to carry her more or less into the room where the anesthetic and surgery was to be performed. Dr. Mickelson applied a teaspoonful of chloroform onto a handkerchief and placed it over her mouth. She breathed in deeply a few times, and then all of a sudden, as the surgery started, she stiffened, blanched, and died. They dashed cold water and gave brandy, but no resuscitation was eventuated, and the whole process of inhalation, operation, venesection, and death took no more than 2 minutes. She'd undergone ventricular fibrillation and died. Now, she was not the first, she was the first, but she was not the last. There were multiple deaths under chloroform, so much so that an investigation was held to establish what to do around the chloroform question. And they recommended this, importantly, use a mixture of anesthetics, i.e. use balanced anesthesia, so you decrease the toxicity from one agent by applying a number of different agents. Balanced anesthesia concept was later developed by Dr. Lundy, who I will talk about in a few minutes. Despite these recommendations, in 1909, more people died from chloroform than were murdered in England. It was a public health emergency. And still we continued its use till 1952. Cyclopropane was the next serendipitously found anesthetic with a problem. Cyclopropane was investigated as a toxic potential gas from propylene, terrible names these so early in the morning, and has found to anesthetize cats. So it was incorporated into anesthetic practice. It was particularly popular because it maintained blood pressure and patients could be anesthetized very quickly. However, on October 31, 1938, Mary Laheath died. An explosion occurred in the operating room, a popping sound around the airway, and she ruptured her trachea and died of subcutaneous emphysema. So cyclopropane exploded, and this was the first recorded death from cyclopropane. That year in America, 95 deaths from cyclopropane explosions occurred, and over the next 40 years, there were multiple operating rooms that were exploded away, including the anesthesiologist, the resident, and the nurses and patients. The last serendipitously found agent was trichloroethylene. The world was really ready for a design drug, and that was initiated with the use of halothane, which basically brought in the modern era of anesthetic as a novel, non-flammable agent. And the rest of the agents that we know and love are displayed on this slide. Now we will move to the concept of balanced anesthesia and discussed briefly intravenous anesthesia as well as muscle relaxants. John Lundy, who coined the word balanced anesthesia, taped a cotton wool swab to the philtrum of the nose. He was very concerned about any respiratory depression occurring as he injected intravenous thiopentone. He was one of the first progenitors of the use of intravenous agents for anesthesia, and to be sure that he was truly intravenous, he would place the needle, draw back blood into the sulfurous colored thiopentone, make sure there's blood in there, and then he would inject slowly, 3 cc's, telling the patient to count to 10. If the patient was not asleep, he would give a little bit more and tell the patient to continue time until they were asleep. He had experienced and published over 3,000 patients, and this inaugurated the use of intravenous anesthetics. Thio, as we call it, was not the first, but it was the most well-accepted intravenous anesthetic agent, and subsequent agents were produced as demonstrated on slide, all more or less having the same problems of varying degree. Today, these are no longer with us, but the following drugs are now reformulated drugs of either with alpha-oxalone, etomidate, or propandate base. Now we turn to muscle relaxants and the story of curare. Now, curare was originally an extract from the liana plants in South America. This extract was used to poison darts to shoot birds on the flight by South American Indians of the time. This extract found its way to France, where it was investigated by Claude Bernard, who identified that it worked at the neuromuscular junction. It had been recently popularized as a drug called ecocitron, and ecocitron was being used to minimize skeletal damage during convulsions induced by electroconvulsive therapy. Harold Griffith was a redoubtable, pudgy, merry man who loved to smoke a pipe to relax. He was a Canadian anesthetist, and he mused what anesthesiologist would not like the muscles to be relaxed in the abdomen when a surgeon is doing a difficult operation. He'd obtained some curare and was planning to use it. The opportunity arose when he was anesthetizing a 250-pound plumber for a most difficult appendectomy. And surgeons were struggling to open the abdomen, and so he said to his resident, Enid Johnson, give 3 cc's of ecocitron. So he gave 3 cc's of ecocitron, and the muscles were as soft as dough. And so muscle relaxation was incorporated into anesthesia. And to boot, he could decrease the dose of chloroform, so balanced anesthesia was part of the process. From then, of course, we had a development of all kinds of muscle relaxants, and all with varying problems that we know and have to address. Realizing that many of the muscle relaxants were long-acting, we then moved to shorter-acting muscle relaxants, and in fact tried to find an alternative for succinylcholine with ill effect, of course, rapamycin, killing quite a few patients because of the irreversible bronchospasm. So the drugs that we have today are enumerated on this slide. Now looking at facets that enhance the safety of anesthesia administration, starting off with airway management and ventilation. After the first mask that was developed to minimize obstruction from cloth containing ether, we moved to Sir Frederick Hewitt. Sir Frederick Hewitt had failing eyesight, and as a result he decided to go into anesthesia. Holding a mask would be not considered too taxing for him with his failing eyesight. He was most highly regarded because of his calmness in emergencies, particularly airway emergencies, and he defined this first airway obstructive device. The next one was Arthur Goodell, who modified it somewhat by having a curvature which would allow access to the glottis much more easily and to avoid the tongue falling back. Now, if obstruction continued during the course of the anesthetic, the only way to approach this was to do a tracheostomy. until the development of endotracheal tubes, the first metal tube, the first flexible metal tube, and the first silastic or cuff tube. The cuff tube, of course, protecting the airway from any aspirated material. Now, the problem for many in the United States was that we were not adopting this approach. Arthur Goodell was a self-made man. He was exceedingly poor, couldn't go to high school, so he apprenticed to a machinist, cutting off his 3 fingers as part of the process. Nevertheless, he found his way to Indiana University and eventually became the chair of anesthesia at the University of Southern California. He'd established that here in America, people were not widely embracing cuffed endotracheal tubes. I think this might be from your chapter, this picture. And so he developed a dramatic approach, much as done in the past. He developed a traveling sideshow incorporating his pet dog, and his pet dog was called Airway. He wanted to demonstrate the fact that if you use the cuffed endotracheal tube, the dog would not drown. And so what he did, in front of a crowded audience, he anesthetized his pet dog Airway, intubate with a cuff tube, and then invert the said dog in this aquarium underwater, so that he could anesthetize and continue to anesthetize for the next 60 minutes or so. Pet dog Airway just breathed carefully and would have drowned if it wasn't for the cuffed endotracheal tube. Then he extricated the dog, extubated the dog. Pet dog Airway would wake up, shake off all the water from his pelt, and trot out to a loud applause. And of course, after that, most people would have adopted the technique of endotracheal intubation with a cuffed airway. At this time, if you were managing anybody's airway, you either intubated the patient or you had a mask. And you needed all kinds of contraptions to keep the mask on the face, as you can see displayed here. This was before the time and advent of the LMA. Archie Brain, an always well-dressed, dapper man, as you can see on these 2 slides here, never meant to go into medicine. He studied languages at Oxford, but was so interested in the science of medicine that he decided to go into medicine. Archie also never decided to go into anesthesia. When he arrived at the surgical job that he'd applied for, it was gone. So they said, why don't you do anesthesia instead? And he did. And 6 weeks later, he said, I just loved it. I absolutely just loved it. Becoming a lecturer in London, he decided to start working on some inventions that might improve the safety of care in anesthesia. That's what he specifically wanted to do. And he always said that he found using a mask somewhat awkward in practice. Now, at the time, he was doing a lot of dental anesthesia with something called a Goldman mask. This Goldman mask you just put over the nose so the dentist can go. And he thought that holding the mask was a difficult thing. So, with his artistic mind, he thought of the parallel between the nares and the glottis. And he thought, well, if he can put the Goldman mask over the nose, why can't he put the Goldman mask over the larynx? So he traveled to the London Institute of Laryngology, got a whole lot of specimens from there, and practiced developing a device in his kitchen. And this is what he developed. He took a Goldman mask and a Portex tube, added them there together, and so we have the first LMA. He tried it first on himself and tells me that he spluttered a bit, but he could breathe through it. And so he developed a number of prototypes. And too scared to use it in his own institution, he took it on the road when he was doing a locum in the north of England. And he'd anesthetized the patient, put it in, and to his big surprise, he could hand ventilate the patient. And from that, of course, we had developed the LMA. He tells me now that he is most pleased. He doesn't practice anesthesia anymore. He's actually an artist in Japan. He tells me now that one of the greatest things that pleases him when he's heard about another LMA saving a life, and it certainly has. Before the 1930s, if you stopped breathing, that was it. Electrocution, anal stretching, vain attempts with bellows in the mouth were attempted, but generally speaking, if you stopped breathing before the 1930s, you were done for. It is true, there was insufflation anesthesia at the time. You could put a catheter into the lungs, but actually positive pressure ventilation didn't really occur. Now, Bernard Drager had developed the pulmotor. This was used largely for resuscitations in ambulances and at the side of swimming pools, but not in the operating room. Polio had come and gone, and the drinker respirator was developed, but clearly you can't use this in surgery. And the first ventilator was that developed by Dr. Paul Freckner, but it was far too complicated for anybody to use. However, in the 1940s, people were starting to use curare, and now they were starting to use big doses of curare so that patients were fully paralyzed. John Blease was a motorcycle mechanic. He created this 1,000cc motorcycle and raced it in Southport, being the uncontested champion. He was befriended by a local anaesthetist, Dr. Robertson, and asked to improve his anesthesia equipment. Robertson died, and he took over the practice, never having trained in medicine at all. He was such a good anaesthetist that in 1940, during the Second World War, he was drafted as an emergency anaesthetist. He too got tired of hand ventilating the patients. And so after putting together the mechanics of basically a motorcycle, he developed the first Blease manly ventilator, which is the large use ventilator that many of us have had the pleasure of using. The enhanced safety that we experience today has been to a large extent the enhanced monitoring that we have and the keeping of anesthetic records, because this first anesthetic record demonstrates that without a record you cannot measure the outcomes of your intraoperative interventions. So this was a very big step. Notice, by the way, who the surgeon was, John C. Warren. Before that, monitoring was largely done by looking at breathing rate and pupil size. But here in this stage photograph, where John Clover demonstrates the use of measuring of the pulse, he has sat his father down for the stage photograph to demonstrate the monitoring of the pulse as part of anesthetic practice. Blood pressure was introduced in 1896 in Padua, Italy, and Dr. Harvey Cushing from this institution traveled over there and incorporated blood pressure measurement here since 1903. EKGs were usually used around the 1960s. Arterial line is being used throughout the ages, actually, in different forms. CVPs and Swan-Ganz catheters were introduced in the 60s and 70s. Neuromuscular monitoring in the 70s. End-tidal CO2 and pulse oximeters in the 80s. TE in 1998 and EEG in 1994. Anesthesia machines developed from the first one that we talked about to devices that were portable when much of the surgery occurred in people's lounges. And eventually, of course, as operations gravitated to the operating rooms, and as we started using both pipe gases and cylinders, we needed a receptacle or trolley that we could attach all of this equipment to, which inaugurated the Boyle's machine, as you see here. By the way, Boyle was left-handed, and as a result, the rotameters are always on the left side of the machine. So he had that to credit him. Further, we now have, of course, the integrated machines that incorporate both the ventilatory device, the computer record, as well as every sophisticated device that has measurably increased anesthesia safety and improved our measures of outcomes of care. Now, one of the major protagonists of looking at outcomes of care was Ernest Amory Codman, pictured here, a Boston surgeon and a former anesthetist, and also the author of the first anesthesia record. He proposed that surgeons used end result cards, in which they documented exactly what happened intraoperatively and then looked at outcomes postoperatively. For his troubles, he was vilified, in fact fired from a Boston hospital, and went into private practice for this approach. I told you earlier about the mortality, 300% mortality in one case, and I told you that mortality was particularly poor before 1800, before the advent of anesthesia. The very first academic study of mortality in anesthesia was, of course, performed here by Henry Beecher, who was the first academic chair of this department. He studied over 500,000 anesthetics over 4 years in 10 hospitals around Boston, and determined that what he called the anesthesia death rate was 1 in 1,560. And he also called this a public health problem. Now, over the intervening years, for all the reasons that I have explained over the last 40 minutes or so, anesthesia mortality has improved 90-fold in 60 years, from the rate indicated here to the rate indicated here. Still not as safe as commercial airline flying, where the death rate is 1.23 million as recorded, 2.3 million is recorded in 2013. I would just thus say that the balance between safety and death has now become a balance between safety and toxicity. And here's why. First, we were concerned about organ toxicity, ventricular fibrillation from, for example, from chloroform, or liver failure from halothane. Now we're more concerned about cell toxicity, particularly neurotoxicity, and organ toxicity, as we learn that there's an association between mortality and depth and duration or susceptibility to anesthesia. Over the last 15 years, there have been multiple studies in rats and non-human primates to elucidate the concerns around the potential for increased rate of apoptotic brain cell death. These many studies have unlocked a number of retrospective clinical studies in infants and children, portraying that, in fact, there may be learning disabilities and other disabilities in such children. So much so that more recently, the FDA has put out a drug safety communication raising the concern about cellular toxicity in young children. On the global toxicity side, in particularly fragile patients, we first learned of the study by Terry Monk, who showed that cumulative depth of hypnotic time was associated with mortality, enhanced mortality, bolstered by the work of Dan Sessler with the triple load, who also showed this mortality, and further supported by more work showing an association with cumulative depth or sensitivity or susceptibility to anesthesia and enhanced mortality. Hence, my summary is that we should go beyond a balance between safety and death to a new balance between safety and toxicity. And no matter what you think of what I've just said over the last 45 minutes, you are most alive when you are scared to death. Thank you for your attention.